everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today we will be speaking with Peter Clayton, Emeritus Professor of Paediatric Endocrinology at the University of Manchester in the UK. At the end of this podcast, learners should be able to describe pharmacogenomics and how it can impact the future care and management of patients with growth disorders. This podcast is part of the continuing medical education programme entitled Digital Decision Making in the Management of Growth Disorders 2026, targeting clinicians, particularly paediatricians, working in growth disorder management and those in general practice. Some content may be of interest also to specialist growth disorder nurses.
Hello, my name is Peter Clayton. I am Emeritus Professor of Paediatric Endocrinology at the University of Manchester. I have had a clinical career in the National Health Service in the UK at the Royal Manchester Children's Hospital as a paediatric endocrinologist, and I've combined that with my academic activities at the university.
What are the biggest benefits to patient care from pharmacogenomics that you can see being part of clinical care within the next 5 years?
I'd like to start answering that question by thinking about what the definition of pharmacogenomics means so that we're all starting on the same page. So the use of pharmacogenomics in looking at efficacy and safety of drugs involves identifying genetic variants that can affect responses, that's efficacy, and or safety. And that field of work has been around for many years, and there are many aspects to pharmacogenomics, identifying genes and the protein products that affect the metabolism of a drug, for instance, which is very important then to both efficacy and safety. In terms of my field in paediatric endocrinology and growth disorders in particular, pharmacogenomics has not played to date a huge part. If I think about the history over my career, growth disorders were assessed from a clinical point of view, from their phenotype and the growth performance of the child. And this was followed by tests. They may be radiological tests, an X-ray for bone age or a scan of the brain, hormone tests, in particular looking at growth hormone levels, and then a decision about what that diagnosis may be and what the treatment for that diagnosis should be. In my early career, genetic testing was limited to a karyotype, and then single gene tests became available. So in the last 10 or more years, that side of growth work, growth investigation, has changed quite dramatically with the advent of much more detailed genomics, moving from looking at multiple individual genes for the possibility of a diagnosis through to now looking at the whole exome or the whole genome in some circumstances to make a genetic diagnosis. And I emphasize the issue of talking about a genetic diagnosis because that in many ways is the first step in a pharmacogenomic process, because if you know exactly what the diagnosis is from a molecular point of view, then that can help you to start with to pick the right drug. I think we have come to recognize that in the growth disorders that we manage, there are complex phenotypes, there are multiple morbidities, and we're starting to recognize with genomic studies that some children have more than one genetic growth disorder. As such, you need to have complex testing in order to be able to sort of fully describe what these disorders are, what their etiology is, what molecular pathways may be involved, and therefore, as I've said before, what is the right treatment. So I think that's the sort of background thinking about genetic testing as part of the first step in pharmacogenomics. I then think we need to think about the growth disorders themselves. Obviously, there are multiple growth disorders, but the ones that get treated currently with growth promotion, for instance, all the different types of growth hormone deficiency, but also non-growth hormone deficient conditions like Turner syndrome in girls or children who are born small and stay small. I think that group are a particularly good group to think about from a genetic point of view, because describing a child as being born small for their gestational age and staying small is merely a phenotypic description of the growth disorder. It doesn't tell you about the molecular cause. And there are clearly, we're coming to understand, multiple causes for children to be born small that have a genetic basis. The treatment that we use in these conditions, and I haven't mentioned all of them, but those are sort of primary conditions treated with growth hormone. The treatment, of course, for many years, there's been one treatment, that is daily growth hormone injections. Initially pituitary derived, and then from the late 80s onwards, recombinant human growth hormone. And that, in general, has been a safe and efficacious treatment. The dosing for each of these conditions has been somewhat empirical, and the non-growth hormone deficient children tend to get larger doses than the growth hormone deficient ones. And what we've come to recognize, not only in growth hormone deficiency, but all the other conditions, that the growth responses are very heterogeneous. And where you're dealing with conditions that have a range of responses, it would be good to know how your child might respond at the start before they even start the treatment. And that is the basis of sort of introducing a pharmacogenomic approach. This was initiated in our field quite a number of years ago, looking at single genes. And some of those single gene variants in small populations were shown to have an effect on or to be related to the response. But as the years have gone by and bigger cohorts have been looked at more carefully, and then starting to look at multiple genes that might influence response to growth hormone, I think the landscape's got a bit more complicated. I think where we're up to currently in terms of variants in single genes in the DNA, it is very likely that the response to growth hormone is actually under the control of many different genes that are having minor effects, but when they're all together, can account for that variability. But we really haven't got to the stage where we can quantify exactly what all of those genes are and what each of their contributions are. We were involved in those DNA variant studies, but we then went on to look at gene expression profiling. So when you're looking at gene expression, you're looking at the messenger RNA, so the product of the DNA. And you can look at all of the messenger RNAs that are expressed by a child and see which ones are related to the growth response. That is what we've been doing over the last number of years. And we've demonstrated that these gene expression profiles can indeed be shown to have an impact, or they are influencing the growth response. We've looked at those gene expression profiles both on their own and in association with baseline clinical characteristics, which we know determine response. And we've shown that the gene expression profiles contribute significantly to being able to predict response. We've done those studies in a number of populations and can show that in different populations and different growth disorders, you can use baseline gene expression profiles to predict response. And I think that that is, from a management point of view, a helpful thing to be able to do with a family when you're starting out a decision about treatment. What's the likelihood of a good response versus the likelihood of a not so good response? And how does that affect your decision making about starting treatment or start thinking about the starting dose of treatment? The aspect that I want to draw out, though, about the studies that we've done is that the obtaining of the blood sample for messenger RNA extraction is straightforward. It's like any other blood sample, but the processing of that sample is quite complicated. The generation of the gene expression profile is becoming more and more straightforward, but still generates a large amount of complex data. And then the analysis to link the genes, the gene expression that is related to the growth response, that is complicated and requires AI techniques and tests such as random forest, which will allow you to pick out the best predictors. So at the moment, we're at the stage where this has been shown to be very possible at a research level, but not really very practical at a clinical level. And I think quite a lot more work needs to be done in order to take that next step into a more routine clinical approach. Now, one way of doing this is to look in the gene expression profile. So look at the mRNAs that are predictive of response and see whether they have any relationship to a DNA variation, what's called an expression quantitative trait loci, where that variant in the DNA is directly related to change in that mRNA that you found to be predictive. If we're able to do that, and we've shown that in some of our profiles you can find these EQTLs, then that would make for a much easier clinical test on a DNA sample. And I think that that's something that needs to be worked on going forward. I think the other aspect that is changing in terms of treatment is that we've gone from having daily recombinant human growth hormone injections to a choice of whether you should have daily injections or weekly recombinant human growth hormone injections. So that's quite a change in the treatment landscape. And even more recently, there are drugs being introduced that affect growth pathways. They've been used in a very rare condition of achondroplasia, but also are starting to be looked at in commoner growth disorders. And I think that that's then going to start to change the field of growth treatment. And therefore, that first step of which might be the right treatment for my child may become a bigger issue than it has been in the past. I think it's also fair to say that at the moment, pharmacogenomics in the growth field has been focused much more on efficacy than on safety. Whereas in the past, pharmacogenomics were or have focused on both of those areas. So I think looking at safety in the future with pharmacogenomics is important. I think one of the caveats I would say for all of this work is that the numbers of subjects that any one center has are relatively small for each of the growth disorders. So you have to have international collaborations to bring together enough samples. And even then, the sample numbers are much lower than they are for lots of common disorders where pharmacogenomics is being used. So I think that that's one caveat that we always have to think about. But I think that is where we're up to in terms of what's happening now and what is going to be happening over the next 5 years. I've been in this field for about 10 years, and I think you could say that things aren't moving that fast. But with the way that techniques change and the way that AI is moving things forward, then that could accelerate quite markedly.
Can you see pharmacogenomics being used to help patients with very rare growth disorders, or will the benefits mainly be for those with established disorders?
What I started out by doing is talking about making a genetic diagnosis as part of the first step in pharmacogenomics, so that, if you know what you're dealing with, you can make an appropriate drug choice. And I think that that applies very well to rare disorders, very rare disorders. I think there is a need internationally to have databases where we can draw together these very rare disorders to make collections of these very rare patients where we can derive some better insights. But what the genetic testing is doing in these very rare disorders is pinpointing where the problem is from a molecular point of view. And that might be in a general cellular pathway, or it might be specifically in a growth pathway, or it might be something that relates to both general function and also that includes growth. So that knowledge is important when making a decision about treatment. Would growth hormone be the right treatment? Should this child have insulin-like growth factor 1 rather than growth hormone as a more downstream hormonal treatment? Or should some of these newer drugs that actually modify growth pathways be appropriate for that very rare growth disorder? So I think actually that's sort of happening at the moment. That kind of thinking and that sort of process is happening at the moment. When you mention, will pharmacogenomics apply more widely? We've already talked about the range of growth disorders that a pediatric endocrinologist sees, and I think it does apply across that range of growth disorders. I mentioned a few, but not all. But I actually think that you can possibly take pharmacogenomics even further in some of those disorders. For instance, in growth hormone deficiency, we have used gene expression profiles to relate that to the growth hormone levels that are found on stimulation testing. And it's the stimulation test around the world that determines whether you are considered growth hormone deficient or not. And we've shown that gene expression profiles can be correlated to that range of growth hormone levels in the deficient range. So you may be able to use a gene expression profile both to help you with the diagnostic process and then help you with the prediction process of response to whatever drug you choose. So that might simplify the investigations that children have if you were able to have sort of one profile that answered a number, both a diagnostic and a therapeutic question. I think the other thing that is being looked at is other growth-related disorders. Puberty is intimately related to growth, and we're very familiar as pediatric endocrinologists with puberty disorders, either puberty occurring too early or puberty occurring too late. And we have been using gene expression profiles to see whether we can predict those children who might go off into a very early puberty or might be heading for a delayed puberty. And there are other endocrine conditions, for instance, adrenal disorders, which are treated with glucocorticoids, where studies using a range of omic techniques to define the response to glucocorticoids are helping to define what the right glucocorticoid or the right pattern of glucocorticoids for treatment of that child's adrenal disease. So I think we will see developments in our field of pediatric endocrinology moving out from not just growth disorders, but into other endocrine disorders that we manage.
What take-home messages do we have at the end of this podcast?
I'd like to finish by just going over some of the messages that I hope I've shared with you. So I think the first one is that growth responses to recombinant human growth hormone, as the commonest growth treatment, show significant variation in all conditions where it's used for treatment. And this makes a strong case for better understanding of factors that determine this variation. Now, to date, this has been done by looking at baseline, clinical, and growth phenotype, but we have shown that using pharmacogenomics on RNA profiles can help with prediction of growth outcomes. I've also made and emphasized the point that a genetic diagnosis can be, and often is, a first step in the pharmacogenomic process. And this may, for instance, help by providing a basis for choice of therapy, or in some cases where you've made a genetic diagnosis where there's a predisposition, for instance, to a cancer, may well indicate that giving a growth-promoting treatment is not the right thing to do. I've also talked about studies that have looked at DNA variation in multiple genes for their association with growth responses. And it's certainly true that many genes have, over the last 20 years, been implicated in growth responses to growth hormone. But most of those have not been replicated in follow-up studies. The genes that have been identified, interestingly, are variants that are distinct from those genes that are associated with adult height. So those genes that determine your response to growth hormone are likely to be different from those that determine how tall you're going to get. I have spoken at length on messenger RNA, so gene expression profile to accurately predict growth responses. We've looked at growth hormone deficiency, Turner syndrome, and short children born small for gestational age, and found that in all of these instances, these gene expression profiles are useful in prediction. But I have made the point that currently the test processing through to analysis is complicated and is not fit for general clinical use.
I did mention expression quantitative trait loci, which are sequences of DNA that directly relate to gene expression. It is therefore possible to identify EQTLs that relate to individual genes within the baseline messenger RNA gene expression profile. A test on sequence variation in DNA is much simpler than doing the full messenger RNA gene expression profile, and would be much easier to use in routine clinical management.
And I've also talked about how predictive genomics may help with the decision about therapeutic options. Now we've got more of a choice of therapeutics in growth disorders and a choice about what dose you might start with, be that, daily or long-acting growth hormone, recombinant human IGF-1, or some of these newer growth-promoting drugs which impact on the basic growth signaling processes. And those are currently in trial. Thank you.
Thank you for listening to this mid-year podcast. For more information about our continuing medical education programs, please visit our website at midiaacademy.com.